Hi everybody, this is Mazen Judi, Assistant Professor in the Baghdad Medical College. By name of God, I will start this presentation in Oncology Made Easy series about breast and special therapeutic problems of breast cancer. In this lecture, we will discuss four important issues. First one is about the phyllodes tumor. Second one is about the paget disease. Third one is about the occult breast cancer, and the fourth one is about the breast cancer in pregnancy. Phyllodes tumor. The term phyllodes tumor includes a group of lesions of varying malignant potential, ranging from completely benign tumor to borderline tumors and into the malignant type of phyllodes tumor. It can affect any age group, but usually in the fourth decades of life. And the percentage of phyllodes tumor classified as malignant range from 20 to 50% of the phyllodes tumor. The prognosis depends largely on the status of the surgical margin. That's to say, when the free section margin more than 1 centimeter, the risk of recurrence will be less. And although the metastasis can occur primarily to the lungs. The basis of the nature of the phyllodes tumor is different from the invasive ductal carcinoma. That the tumor is of soft tissue. That is because of the histology of the breast, composed of epithelial tissue and also soft tissue component. And the classification of the phyllodes tumor being benign, borderline, or malignant depend on the features, histological features of the disease. That's to say that the degree of cellular atypia, mitotic activity, and overgrowth in the stroma. And there is disagreement about which of these criteria is the most important criteria for definition of the malignancy of this tumor. Although the most experts favor the stromal overgrowth of the malignancy. Axillary lymph node dissection is not indicated in this type of breast cancer or breast malignancy. Local excision to negative margin is an appropriate management strategy for both benign and malignant phyllodes tumor. Of course, if this can be accomplished with satisfactory cosmetic outcome. And the optimal margin width is not known, but wider excision appear to reduce the risk of local recurrence. Axillary metastasis forms about 5% of all cases of the phyllodes tumor. So axillary surgery is not indicated for this type of malignancy. When phyllodes tumor metastasizes, in this condition will be treated like any type of sarcoma rather than being of breast cancer. Now, clinically, phyllodes tumor are smooth, rounded malignancy, usually painless and multinodular lesion that may be indistinguishable from the fibroadenoma. So, in the examination, we can find bubble mass that may be with ulceration. And this bubble mass has history of rapid growth, usually large size, and the size may be more than 3 centimeters. Imaging tests are used for the diagnosis, and these imaging tests include the ultrasound, is very important, and mammography also. This picture is showing the mammography features of benign disease, which is the fibroadenoma, and the malignant disease, which is the phyllodes tumor. Difference present in the size, in the shape, and the margin between these two lesions. The diagnosis may depend on the by the core needle biopsy. Fine needle aspiration is not beneficial. The fibroadenoma will give features are benign looking proliferation of both the stromal tissue and the glandular tissue. This is stromal tissue and this is glandular tissue, and this picture showing the proliferation of benign looking features. While here this picture showing the clefts that are seen in the phyllodes tumor, and these are long clefts and myxoid stromal substance. This part of the tissue showing normal breast tissue. So the diagnosis for the phyllodes tumor depends on the biopsy by core needle biopsy. The treatment for the patient with malignant phylloid tumor, whether benign, borderline, or malignant, is surgical excision with free-section margin. If the biopsy by excisional biopsy showing fibroadenoma, just observation. While if there is malignant phyllodes tumor or benign or borderline, there will be wide excision without axillary staging. Yes. Now, if there is local recurrence of this disease following excision of phyllodes tumor, we will follow the same treatment as history, physical examination, ultrasound, work up the same ultrasound, mammography, and also consider the chest imaging for any metastasis. If there is no metastasis in this condition, we will do another re-excision, so surgery again, but also without axillary staging, as we see here. While if there is metastatic disease in this condition, will be treated like any metastatic soft tissue sarcoma. This figure from the NCCN guideline, in which showing if there is recurrence with no metastatic disease, there will be re-excision again with wide margin without axillary staging. This is very important to avoid the patient complication of axillary lymph node dissection. The second issue that will be discussed in this lecture is about the paget disease. Paget disease represents in situ carcinoma of the nipple, and the clinical features, these are in the nipple itself, when the patient may suffer from nipple skin lesion as crusting, erosion, discharge, or nipple retraction. All these features can be seen in the patient with paget disease. Usually it is unilateral and rarely can occur bilateral, and very rare also can occur in male patient. Definition of paget disease depends on the presence of malignant cells in the epidermis layer of the skin. When we see these, like these malignant cells in the epidermis layer, this will diagnose the presence of paget disease. While if there are malignant cells in the dermis, this is not a paget disease. So by its definition, characterized by presence of malignant cells in the epidermis layer of the skin of the nipple. Now, the workup for patient with the paget disease, of course, starts with history and clinical examination. For the nipple skin lesion, we can see skin lesion only without underlying mass, or we can see mass by examination underlying the nipple. Of course, the tools for the diagnosis include bilateral mammography and ultrasonography. But sometimes it will not visible, the mass will not be visible by these measures, so we use MRI for diagnosis of the mass in the presence of the paget disease. So there are three possibilities in which the paget disease diagnosis: either breast cancer as ductal carcinoma in situ and nipple areolar complex paget disease, or maybe there will be breast invasive cancer associated with nipple areolar complex paget disease, or maybe only nipple areolar complex paget disease without presence of any mass. Really, there is two theories for the presence of the malignant cells in the epidermis. The first theory, what is called intraepidermal theory. That is to say, there is in situ intraepidermal malignancy with secondary extension of the malignant cells to adjacent structures. While there is another theory, what is called epidermotrophic theory, in which the malignant cells are present in the mass, but there is invasive cancer in the mass with invasive cancer, and there is epidermotrophic. These are malignant cells will migrate towards the epidermis. Yes. Historically, the paget disease was treated with mastectomy previously. That mastectomy was the cornerstone in the management of the paget disease. But nowadays, local excision of the mass by cone excision, that's to say removal of nipple areolar complex, and the cone excision to the mass underlies it, and then breast shape conserving surgery is enough for the treatment for the paget disease. So for the diagnosis, we have to have full thickness skin biopsy to involve the nipple areolar complex, and if the nipple areolar complex biopsy negative for paget disease, clinical follow-up or re-biopsy if not healing. While if the nipple areolar complex biopsy showing paget disease, now consider breast MRI and tissue sampling, and to be followed by surgery, whether central lumpectomy including the nipple areolar complex with whole breast radiation, or total mastectomy with or without sentinel lymph node biopsy, or without breast reconstruction. And there is other choice, which is the central lumpectomy, including the nipple areolar complex plus minus sentinel lymph node biopsy without radiation therapy. And this choice showing category 2B according to the NCCN guideline. As we see here, if the patient has paget disease, we have multiple possibilities that breast cancer and as invasive breast cancer and nipple areolar complex, and this condition will be treated like any invasive breast cancer. While if the breast negative for cancer and positive for nipple areolar complex, now there is a big role for the MRI to be considered and tissue sampling, and then we have three possibilities as we mentioned: either central lumpectomy including nipple areolar complex without whole breast radiation therapy, or total mastectomy plus minus sentinel lymph node biopsy with or without breast reconstruction, or central lumpectomy including the nipple areolar complex plus minus sentinel lymph node biopsy without radiation therapy. So now we discussed two issues, which were the phyllodes tumor and also paget disease. Now the third issue that will be discussed in this lecture is about the breast cancer and pregnancy. Breast cancer now estimated as occurs 1 in each 1,000 pregnancy. Previously, the estimation for breast cancer during pregnancy was 2.2 in 10,000. But nowadays, because of early detection, an increase of the estimation and the incidence of the malignancy breast cancer in the pregnancy is about 1 in every 1,000 pregnancy, which is this large incidence. It's not small incidence. Breast carcinoma, of course, is one of the most common diagnosed malignancy during pregnancy, and the delay in the diagnosis remains a problem due to the nodularity of the pregnant breast and the assumption that the new breast masses are normal physiological changes that occurs during the pregnancy. Now, for the diagnosis, the dominant breast masses developing during pregnancy require what? Require biopsy before assuming that they are benign. If excisional biopsy is necessary, it should be undertaken concern about the development of milk fistula that appears to be overstated. So biopsy is required for the diagnosis of malignancy in pregnancy. Mammography is not useful for pregnant patients. Why? Because this may cause increase because of the increase of the parenchyma during pregnancy. So mammography is not a useful tool in pregnant patients. The most important tool for diagnosis of breast mass as malignancy is ultrasound, that may be helpful confirming the presence of dominant mass. Normal imaging studies should not lead to decision to leave biopsy in the patient with dominant breast mass. The problem in the CA breast in a pregnant woman is in the staging. After diagnosis, the initial evaluation should include an assessment of the extent of the disease. CT and bone scan, of course, are not recommended during pregnancy. Why? Because radiation exposure may affect the fetus, and this may lead to congenital malformation. In patients with symptoms suggestive of metastasis, in this case, MRI without contrast media is used to evaluate the bony sites and the intra-abdominal viscera. So initial diagnosis for patient with breast mass as malignancy in the pregnancy is by ultrasound, and biopsy is important. If there is diagnosis of breast cancer, now staging depend on the MRI study rather than CT or bone scan. Now, regarding the management for breast cancer during pregnancy, of course, multidisciplinary management by a team is important for the management of this condition. And this team includes medical, surgical, and radiation oncologist, and obstetrician also. A maternal fetal medicine specialist also is important. Psychologists also play a role because this will cause a big psychological problem to the pregnant female. And all this, the team is important to take decision that is proper for specific patient. Breast surgery can be safely performed during pregnancy at any trimester of pregnancy, but the type of surgery is different according to the trimester. There is no evidence that pregnancy termination changes the clinical outcomes or survival for pregnancy-associated breast cancer. So termination of pregnancy is not vital for any patient with a pregnancy. And also the sentinel lymph node is not very useful in the pregnancy because the dye that is used by the pregnancy by the diagnosis of sentinel lymph node is not approved by the FDA approval. It has no approval by FDA, which is the isosulfane blue. Although the technetium, there is controversy about the use of technetium as a dye in the diagnosis of sentinel lymph node. The radiation exposure to the fetus from the use of technetium has been estimated to be low, and it has been suggested that mapping with technetium alone could be discussed with patient as an appropriate management strategy. This is regarding the auxiliary management in the patient with breast cancer during pregnancy. And the mastectomy is the traditional operation as it affords definitive local therapy, and therapeutic radiation doses cannot be delivered without excessive fetal exposure during any trimester. That's to say, after we diagnose the breast cancer in the pregnant female and it is found to be localized, then there is choice of surgery as usual, and the surgery usually mastectomy if it is in the first trimester, because if we do breast conservation therapy, then the patient should undergo radiation therapy, which will affect the fetus. And regarding the axillary lymph node dissection remains the standard management strategy because the use of the sentinel lymph node biopsy and the dye may be also teratogenic and may cause complication during pregnancy. This from the NCCN guideline showing in the first trimester diagnosis of breast cancer, the termination of pregnancy should be discussed, and then or continuation, if there is continuation of pregnancy, then mastectomy plus auxiliary staging. While in the second or third trimester, here there is two choices, either mastectomy or breast conservation surgery with auxiliary staging, or neoadjuvant chemotherapy followed by mastectomy or breast conservation surgery plus auxiliary staging. Of course, if it is in the third trimester, there is two choices, whether mastectomy or breast conserving surgery plus axillary staging. Now the patient diagnosed with the breast cancer and undergoes the surgery, and then the patient need chemotherapy for the treatment. Which type of chemotherapy can be used and which type is safe? The risk of congenital malformation from cytotoxic therapy is different according to the fetal age at exposure and according to the chemotherapeutic agents that are used. First trimester exposure is associated with high percentage, about 10 to 20% of congenital malformation. So the drugs in first trimester should be chosen very carefully. And this congenital malformation decreased to less than 2% with the exposure in the second and third trimester, and this enabling chemotherapy to be administered in these trimesters. Regarding the adriamycin cyclophosphamide, can be used in the second trimester as AC protocol. Methotrexate should be avoided, MTXY, because high risk of abortion and severe fetal malformation. Trastuzumab, which is used in the pregnant female with HER2 positive, this should be contraindicated during pregnancy because of the oligohydramnios. By the way, most of the breast cancer in pregnancy shows ER/PR negative and HER2 positive. If the cancer was hormonal positive, then tamoxifen should be withheld until after delivery because its safety is uncertain during pregnancy. When chemotherapy or tamoxifen given postpartum, breastfeeding here should be avoided. Why? Because this agent may be excreted in the breast milk. The other issue that will be discussed in this lecture is about the occult primary tumor as breast cancer, occult breast cancer with axillary metastasis. That is to say, the patient has axillary mass and without presence of the breast mass. And this axillary mass, if carries high risk of being breast cancer, there will be specific management for this condition. Of course, it is an uncommon presentation of breast cancer and it forms less than 1% of the cases. So in this condition, there is axillary metastasis in the absence of clinically or mammographically detectable breast tumor. The initial evaluation should include detailed history and physical examination, bilateral breast mammography, breast MRI, if the mammography is unrevealing. MRI identifies the primary tumor in the breast in a significant number of patients with a normal mammography and breast examination. And actually there is a meta-analysis about 200 patients with occult primary tumor. MRI identified the suspicion of about 70%. So MRI here plays an important role for the diagnosis of occult breast tumor showing axillary metastasis. The presence of the immunohistochemistry positive as ER/PR or HER2 overexpression is strongly suggestive for the presence of metastatic breast cancer. Although their absence does not exclude primary breast tumor. Of course, if the patient has breast cancer as triple negative, may show metastasis to the axillary lymph nodes, and this condition it is occult breast cancer showing triple negative features. The identification of the primary tumor within the breast simplifies local management, allowing these patients to be treated with breast conservation, surgery, or mastectomy according to the standard guideline. In cases which the primary tumor cannot be identified, treatment has traditionally been with mastectomy. And this based on the observation that approximately 50% of patients who do not receive therapy to the breast will develop clinically evident disease in the breast after mastectomy. The occult cancers found in the breast at mastectomy were sometimes quite large. After the mastectomy, they found occult breast tumor that is not seen by the usual imaging tests for the diagnosis of breast cancer. There are many trials to avoid breast surgery where whole breast irradiation is used, as for example the Forcott et al. When treated about 54 patients with whole breast irradiation without removal of the primary tumor. The 5 and 10 years rates of ipsilateral breast tumor recurrence were 7.5 and 20% respectively. So there is a choice of use of whole breast radiation instead of doing mastectomy or surgery. Other small studies confirm that whole breast irradiation with a dose about 50 gray is an acceptable alternative to mastectomy in these patients with occult tumor. In comparison with the mastectomy, rates of local recurrence after breast conservation therapy are higher in patients treated with excision of a non-primary tumor and a booster dose radiotherapy to the tumor bed. And regardless of the management approach chosen for the breast, axillary lymph node dissection, of course, because the patient's first presentation is axillary mass, so axillary lymph node dissection should be carried out because of the limited ability of radiation to control gross axillary disease. Now, I hope to share your opinion regarding a case of 40 years or 41 years old female presented with breast mass about 4.7 centimeter in size and two-cut biopsy showing the diagnosis of phyllodes tumor. Now, I'll ask you which type of surgery is recommended for this patient and if she developed recurrence after first surgery, does surgery has a role in the management again? And also, I hope if you can answer me for this question as MCQ. A pregnant female in first trimester has a malignant breast mass about 2.5 centimeter in size, showing ERPR negative and HER2 positive. Mastectomy done for her with axillary lymph node dissection. Which of the following drug is contraindicated for her during pregnancy as it causes oligohydramnios? Docetaxel, MTX methotrexate, trastuzumab, or tamoxifen? Thank you.